All right, welcome everybody to RxPerience, ASCP's podcast. I'm your host, Chad, alongside my hosting partner, Tom Hansel. And we have a special edition of the podcast today for a couple reasons. This is going to be sort of a regional meeting update on our Southeast meeting, which is occurring in Greenville, South Carolina, starting on June 12th. And we have the pharmacy host of the meeting with us, which is Ross Brickley. But Ross Brickley also is a former president, number 32 in our presidential chain, and is a pillar of industry as well as this being a regional podcast. So kind of can put this podcast in multiple categories for one of our former presidents. So welcome, Ross, to the podcast.
Thank you. Appreciate that invitation, Chad. Glad to be here today.
So I think let's start with what we normally do, which is get your pharmacist origin story. So how did this come to be, Ross, that you came to be a pharmacist? You became a leader in long-term care. You became president of ASCP, and here you are still working with older adults and medically complex patients in the Carolinas. How did your origin start?
Well, that's a great question. And as a young child, both of my parents were involved as administrators, and my mother is a director of nursing and servicing patients in long-term care facilities in the state of Kansas, very rural area. And I was blessed and had three family cousins that were pharmacists, and mentored me early in my career about the special value a senior care pharmacist can play in the community. So I was raised in that, and honestly, in college, I had my first rotation was with a early long-term care pharmacy innovator in the state of Kansas, and he mentored me and exposed me to it. And I think just the family upbringing got me the excitement about taking care of the elderly, taking care of seniors, and the multiple complex conditions they face. And here I am today, still passionate about caring for the aging and trying to do whatever we can to minimize drug misadventures that they face.
That's awesome. So talk a little bit about like how did you're at Neal Medical. How did you end up there? Have you always been there? What was that career path like as you entered this long-term care space?
Yeah, that's an interesting thought here that, as a young pharmacist, I always had entrepreneurial spirit to me, and I was fortunately allowed to open and buy in a couple of years a long-term care pharmacy near Wichita, Kansas. And we opened that up and was servicing largely Mennonite communities there in CCRC communities. So that was my passion at the time, working with a Mennonite hospital and doing that. And then through ASCP, actually, I was engaged early on in my career and active, and I got recruited by this company. At the time, they were just called FarmSave, but they were based in North Carolina. Got to be good friends with several people there through ASCP. And next thing I know, I was encouraged to move out there and move into operations with ASCP. So my wife and I sold my pharmacy and took a big leap and a big change to be here in North Carolina. So I've been here over 30 years.
That's awesome. I can appreciate that leap and moving for sure. But I think it's a great sort of testament to ASCP and kind of what our organization has been able to do in terms of networking. It's always been that kind of group where you see colleagues from across the country doing similar work. People share wins and losses and things that they're doing that are innovative and improving their practices and their pharmacies. And you network and you meet people and they become your friends and colleagues, and you see them year every year. And lo and behold, every once in a while it can create an opportunity for something new somewhere else. So that's awesome.
Yeah, Ross, we've known each other for quite a while, and our paths crossed there at Neal Medical as well. I love what you say about the entrepreneurial spirit, and we, as Chad and I, do a lot of these podcasts and get to talk to a lot of pharmacists around our age. And there's a common theme to long-term care pharmacy and having that entrepreneurial spirit. And you took another big leap when you started that pharmacy in Raleigh, because you were at Neal Medical for a while. Then you started a pharmacy, and Todd started a pharmacy in Raleigh and made quite the big impact. And I know that was, I think, more of a franchise. Is that, if I remember that correctly, that they had a few of those pharmacies, and you guys opened that up in North Carolina. Tell us a little bit about that leap of faith.
Yeah, and that was my first personal experience with the private equity world, which adds its own level of complexity to a business operation. But yeah, we partnered with Tom Trite out of the state of Pennsylvania, who had Continuing Care RX, CCRX as we called ourselves, and we created a separate corporation. But we sort of tagged on with their finance HR support model. And we went out de novo and began building a business here in the state of North Carolina. And it was an exciting time and a great experience too, to build a business and then unfortunately face the reality of when private equity decides they want to exit, and you're one of the minority stock owners, you exit with them. So we exited.
So talk about just throughout your career, having seen so much and experienced so much in the long-term care space, a little bit in Kansas and a lot of your work in the Carolinas, and then, as Tom mentioned, some other states. What's changed, and where do you kind of see it moving as we go forward?
Chad, I think about that every day. I continue to see, and we're working on several small projects, actually more innovative. We also own 3 retail pharmacies now, and we're seeing some exciting innovation. I think the challenge is we're seeing aging patients with more medications, more new, vitamin supplements, more complex medication scenarios, and they are walking and fighting to live independently. Mm-hmm. And so we're seeing the struggle of medication management, medication misadventures, drug duplication, drug therapy interactions. It hasn't gotten any easier, Chad. I think there's more opportunities for senior care pharmacists, for our members of ASCP, and for our profession to step up to the plate. I'll be candid to say we've got to fight for payment for our services, which is clearly on my mind today, which I'm sure you're going to ask me about here at some point.
We will, because that is like the number one thing that we're dealing with. But I think you bring up a good point, because even in our policy work at ASCP, you're starting to see things sort of melt together a little bit. So, we got the benefit of PBM reform passing, which really only starts the process of making sure that what those reforms are important to pharmacy, are shaped by pharmacy, because they don't have any teeth. If they don't do the right things, those PBM reforms might not be helpful. But part of that is relevant and reasonable reimbursement. And you have that going on while you have all of this clinical activity around chronic disease and the access program and all kinds of things that the government's trying to do to influence wellness and keeping people well. You have this giant population, which we all knew was going to reshape healthcare. They've reshaped everything else in the baby boomers. And I've not met one early in their aging process that has said, I cannot wait to get to the nursing home. They all are like, I'm not going to the nursing home. And I think what we have to do in the nursing home space is recognize that we've built quite an experience and skill at taking care of older adults on multiple medications with a lot of comorbidities and problems. And those people are now not, they'll be in the nursing home. They'll be even worse sort of examples in the nursing home as time goes by, but they're going to be at home. And we know how to kind of care for them. So how do we take what we're doing here and apply it over to them in the home setting? And we can do that so long as the reimbursement level is reasonable and relevant. And that's kind of the access point between all this PBM reform activity, all of this activity with IRA and cost plus medications at identifying you've got to pay for the services that pharmacists are providing. And those services, particularly for older adults that are vulnerable with multiple comorbidities, multiple meds, are beyond just dispensing and counseling. They are delivery and packaging and syncing, and the pharmacist that does the med regimen reviews, all of that. Those are services that have to be paid for.
Yeah, and it's humbling to me. I was speaking to some professional colleagues recently, Chad, and I was president of ASCP in 2004 and 2005 when Medicare Part D was put into effect. And what a honor to represent ASCP at such a critical, pivotal time of our profession, really. And it was great because prior to that, statistically, I would say less than 50% of our seniors, if they weren't on Medicaid in an institutional or long-term care setting, they were cash, they were private pay. And so we clearly made what I thought was a phenomenal shift in providing more appropriate insurance coverage. But the reality is our payment for services in 2005, Chad, what we're getting paid now for the component of the medication dispensing is largely the same. And so if I went to a business, if I stood there in front of several leading for-profit or publicly traded businesses and said, listen, how would your business operate if you had no revenue increases for your labor cost over 20 years?
Yeah. Volume.
What would you be like?
Right. That's 100% right. You can't make it.
No, for sure. So you guys also, I know you have 3 long-term care pharmacies, but you mentioned earlier that you guys opened a few retail pharmacies as well. Was that, I'm assuming that strategy was to kind of get that, start going after those seniors that are at home with your long-term care experience. Was that the strategy behind that? And if so, are you able to incorporate kind of those multi-dose packaging and delivery and the things that we were talking about?
Yeah, Tom, all 3 pharmacies are actually on the campus of continuing care retirement communities, and we're only servicing those seniors on the campus. And so the smallest one is about 350 IL residents, and we go up into the other 2 are near 500. So small, just concierge level. And this is amazing, but I was covering in there actually a couple of weeks ago, and a new admission came into the campus. She'd been living independently, had some memory deficits. Her daughter was there. I spent 2 hours going through her regimens. She was on multiple vitamins. We cleaned up those, worked with the doctor. I spent about 2 hours on her alone. I only filled like 4 prescriptions that day, but I spent 2 hours with one patient. And I think we, between dispensing a couple of her meds, we made about $15 that day. Mm-hmm. So, but I left that pharmacy with a smile on my face because I know I made an impact on her and her daughter who lived out of state, was concerned she was flying out, in a couple of days. How was her mom going to get managed? So we actually set up her meds. In this case, there was memory deficits. So even the compliance, we had 2 different times. We had the pouch system as well as a multi-dose card. Neither one of those would have helped her. So we actually set her up in a manual medication reminder calendar pack that with driven by batteries, that she gets a 2-week supply, and it alarms to remind her twice a day when to take her meds.
Mm-hmm. Man, that's how healthcare should be. At the end of the day, fortunate for her in that situation because you guys took that extra step, and we're been a transactional healthcare industry, and it's a fee for service. And now the question is well, how many of those patients can you process through as quickly as possible? But there's millions of those same seniors that have the same kind of issues that she has, but doesn't have a pharmacist that can do that, or doesn't have any kind of way or healthcare, and relies on her family members to try to figure it out for them. And I feel like there's going to be a lot of the just as many, if not more, negative stories coming out as our population continues to age. So if you're talking to long-term care pharmacies or pharmacists out there, what would you suggest that they start trying to do to get that community reach, to get that community feel, to get that impact that you've been able to make?
I think clearly we need to keep doing, our company actually this morning, we're committed to the becoming an age-friendly pharmacy. So we are going to be challenge our pharmacists and our pharmacies. They're going to officially hear that in the next few days from our corporate leadership team. But I would say, we've got to do the right thing and take care of seniors wherever they reside. We've got to be passionate about doing the right thing, and we actually know that for those that can afford, in some cases, for this sort of concierge level of service, we have some families now saying, "Hey, we'll pay you for this time involved." But I think ultimately, I would say, Tom, to the pharmacist out there, that we've got to keep involved in ASCP nationally, supporting our associations that are out there advocating for payment for services. My daughter's an attorney. She gets paid in 1 minute segments. That should be no different for us pharmacists, that we're a profession. We take care and we save patients' lives every day. We should be compensated.
And what I love about your story is that you did it. You could say 20 years ago, the margins that pharmacies were able to create in dispensing drugs paid for those services. These are not, I hate when people say we're going to do these new things. I'm like, these aren't new. We've been doing this. Our weird reimbursement system that we had paid for those services in a different way. And now that we've gotten cost reductions in pricing of medications, we have to remember that once you strip out the margin, now how are you going to pay for those services? Because they're still happening. They aren't new. They're happening, and they have to be reimbursed for. And that's what I think about when I hear, you spending that time with that new admission that's coming from probably in an area where there wasn't a lot of coordination, and now finally getting to a place where there's going to be some good coordination. And the first experience is the pharmacist kind of, okay, let's get our hands around your meds, and let's make sure that part starts off well as you enter this CCRC, probably in independent living. And then our goal is to work with you, and we should get paid for that so that you don't move from independent to assisted to skilled. We want you to stay in independent and age in place. I think, I'm ultimately very positive. I see all of these things that are running around different government agencies, and I think it's going to happen. It's never as fast as we want it to. There's already some good examples of where there are some dollars to pick up for pharmacies. We've got to help make that an easy button for pharmacies to engage and get connected to. But I think it's coming. I do think it's coming. I don't think that we can't. I don't think the healthcare system or this country can manage if we don't have pharmacists working with older adults on medications. It's the biggest healthcare intersection that there is. Older people, high use of medication. You can't navigate that intersection without a pharmacist. Can't. Nobody else can do that. So we have to be able to figure out how to do it.
Yeah, and we still see the challenges of the medical community, where it's a complex group of providers out there, and we see multiple medications. We see overlap of therapies, all unintentional, I believe.
Right. It's not their fault.
It's how their system is, and wow, I've just with our retail pharmacies in particular. I mean, we always see it coming in the skilled homes where you do that med reconciliation for those new admissions, and you see excess therapy, you see overlap and such. But man, I've been humbly reminded on the retail side, as we just said in this example, that wow, there's walking, talking seniors out there that aren't taking their medications right, maybe are taking too many supplements, etc., not taking the right regimen. But it's more prevalent than I ever realized. It's everywhere.
Yeah, I think when we've been talking a lot lately, and I'm sure people have heard us to say this, but if you're in a nursing home, you've got a consultant pharmacist, you've got one pharmacy, you generally have one prescriber, you have nurses that are administering the meds to you. That is position A of medication management. Your drugs are packaged for convenience. There's thought around, whether you can handle a tablet or you need a liquid or an injection. That's the only place that happens. And what we're really trying to focus on now when we look at research is we're doing a good job in nursing home patients. I know people don't have a great opinion of nursing homes, but we're doing a good job with med management in nursing home patients. And we need to take that information and start comparing it to the assisted living population and ultimately compare it to the community. Because my guess is, and take something simple like blood pressure, I bet the average nursing home resident is managed on fewer blood pressure meds than the assisted living patient and the community patient. And we just need one little study to point that out, to make it clear that, yes, a consultant pharmacist, huge part of that. Having one pharmacy, whether it's the one you choose or the one that you get when you move into a particular ALF or SNF, those things are really important. That really can be helpful. Obviously, from a packaging standpoint and a sync standpoint, to have your meds delivered on the same day in the packaging style that you want. All those things have a profound impact on your med management. And we do that already. We just need to carry that out. And we need the payers to recognize that carrying that out to patients is a value and something that they should be paying for.
Amen. And we often hear in the hospital setting about barcode scanning to ensure timely, accurate med administration. And we've taken it upon ourselves with our leadership team we've pushed hard and honestly at times I think it's bruised our team just to push forward with barcode scanning. And now we've taken it from the skill setting, and Chad, we're pushing hard in the assisted living that our expectation is we push it the extra mile to say here's the real value of barcode scanning of in our case we're using multi-dose pouches, and we truly believe that's that's patient safety, resident safety.
100%.
And so then you take that, and then like you said, is we got to deal with the multi-prescriber challenges of the assisted living patient and get them on the right regimen.
Yeah, and Ross, I know you guys have a really good clinical program. I know Robert Smith, and he's been there probably as long as you have, and runs a great clinical program. Have you guys started looking at those retail patients, those community patients, and what other than you going out and doing it yourself, which you did for that one lady, but what kind of clinical programs could we expand upon there in those type of settings?
Well, in a fighting environment where we're dealing with the gross margin constraints that Chad outlined, Tom, we've sort of taken the low hanging fruit, and that's where we have focused on the continuing care retirement community model. And that's unfortunately that's oftentimes our upper scale private pay setting.
Mm-hmm.
So but that is where we can get their attention quickly, and we're actually pushing hard in all of our CCRCs to offer the multi-dose packaging and the syncing up of the meds, doing a review on every new client we take in. We review their regimen just like we would for a skilled nursing home patient. It's a complete medication workup. So we're doing that in the CCRC IL. But Tom, you're right. I mean, and I know there's retail pharmacies doing that out there. But sometimes even in our own team, and this is interesting, us pharmacists are so scientific, sometimes I have to encourage our team to say, you need to step back and holistically look at that patient.
Yeah.
Don't look at, okay, hey, what can we do to for their medications and stuff, but you really got to step back and say, okay, holistically, what's going on here? Do we need to peel off some medications? Get back to baseline and then add on as we need to. It's a complex workup.
Yeah. Well, I mean, I'm of the mindset that, if you do the right thing and you prepare for better outcomes than the incomes, will be there. The money will be there. And so examples like that you guys are doing, even though it's a little bit of a controlled environment for those patients that are living in CCRC, they still have, polypharmacy and multiple different meds. They still need to be prescribing. And if you guys weren't there, if you weren't doing that, they probably wouldn't be much different than a retail patient sitting at home in a subdivision somewhere. And so excited to see kind of what comes out of that, and how you guys, potentially, white paper or study or just whatever, not to put more work on you, but it'd be interesting to see, that come to, more statistical, so we can kind of show the value that pharmacists are making for those at-home patients, even if they do live in a CCRC environment.
Yeah, the whole subsidized living for senior setting. Those patients are getting their meds. I've worked up my aunt's regimen the other day, sort of by accident. We were doing a visit, and and she pulled out her bin of medications, and I was shocked. She had 3 bottles of a diuretic from the same medication class she was taken out of, and wow, I had that humbling moment as a relative here, that I hadn't done my professional duty to give my own aunt some medication oversight. But there is such a need in that setting, and I was sitting there thinking as we left last weekend, hey, what can we do with all these wonderful, multi-dose drug delivery systems that we've implemented in assisted living and skilled? Why can't we do that better and more effectively for other seniors in the community, which is what you're getting at, Tom? It's a combination of packaging and clinical skill.
Yeah.
And this sounds like a great CMMI candidate, don't you think, Chad? We should hook him up with Jim, see if we can get something up and running next year with that.
That's right. I love what you had to say about just working with patients and taking that next step of what I heard was the what matters part of the age-friendly process. Like, what matters to this patient? Like, we can make the right clinical decision, but if we don't talk to the patient about it, or the caregiver of that patient about it, it may not work. They may not want to do it that way. They may want it a different way. And it just resonates. And I'm glad you're going through the age-friendly process. I wish I could scream more to all the pharmacies that if you are a pharmacy like yours that does long-term care and has retail or doesn't have retail, if you're in the long-term care space, you have virtually met the criteria of age-friendly pharmacy. You've been doing it for as long as you've been doing it. Your pharmacists do have to get their badge, which is free. It's not a cost. I'm not shilling for ASCP. We would love everybody to be members, but it's not a cost. And it just helps us communicate to the public better when we can say, we're an age-friendly pharmacist, we're an age-friendly pharmacy. I love the term consultant pharmacist. I love the term senior care pharmacist. Some people think that senior care now has some negative connotation to it, but age-friendly, now when I say I'm an age-friendly pharmacist, there isn't this leap of what I do. There's this, I kind of get what you do. You work with older adults. Like, yeah, that's it. That's it. And we're skilled at it. And I think pharmacies can have that same feeling if they go through that process and get that recognition as well. And then what I think you'll see is the GPOs, the CPESN networks, they'll all start talking about, hey, X% or all of our pharmacies that are in our network are age-friendly. And that'll start meaning something to a payer. And maybe meaning something to the opportunity to get reimbursed for different services that you're providing. So that's my goal for age-friendly. I'm glad you're doing it, and I'm glad you're expressing it as what you do every day, because I think some people look at it and they're like, oh, I'm going to have to work to get this recognition. And I'm like, no, most pharmacies, I went to the CPSN meeting. I think all of those pharmacies, all of the pharmacies that are closed door long-term care, they meet the criteria. They just have to go through the process and match their language to the framework, and they're off and running. And once we get that network built, like I said, it'll be powerful and really help us move some of these initiatives. We're moving them right now, but that would really be helpful. Mm-hmm. If you think of a congressperson, say age-friendly, even they probably know what that means.
Yeah. Agree.
Yeah.
Well, Ross, we appreciate Neo Medical being the host for South Central meeting. So that's coming up here in 12th, I believe, 12th, 13th of June in Greenville, South Carolina. So thank you for hosting that, and I'm sure you're going to have a good, solid team there.
Yeah, if you want to visit with Ross's team, or Ross, are you going? Going to be there?
I am.
Yeah.
Yeah, I'll
Visit
be
with
there.
Ross. Visit with us if you're in nearby Greenville, South Carolina. You can register on site. It is next week, July 12th. And we're thrilled to have you host and have you be there.
Well, we're excited to it, and it's it's a great city to visit, and a great city for a regional meeting. So I appreciate ASCP, deciding to plan a regional meeting there.
Yeah, I think it'll be a lot of fun. Well, awesome. Thanks, Ross.
Thank you.
32nd president of ASCP. Thanks for being on, and we will see you next week, and we'll see everybody on the next podcast of RxPerience.